This is a 24/7nursetutors.com lecture. 24/7 Nurse Tutors, providing unlimited tutoring.
Welcome, and thank you for joining us. Neurological System, Part 3.
Let's discuss meningitis. The itis at the end of the word meningitis tells me there is inflammation. Inflammation of the meninges. Entry is via the bloodstream at the blood-brain barrier. It may be a direct route or via a skull fracture. Exudate will develop. The severity of the disease is dependent upon the specific microorganism involved, the presence of other neurological disorders, the general health of the patient, the speed of the diagnosis, and the initial treatment. Viral is the most common, but bacterial meningitis has a very high mortality rate and is most commonly called by the Neisseria meningitidis and Streptococcus pneumoniae. So what is meningitis? Well, meningitis could be caused by a travel of infectious microorganisms to the meninges via the bloodstream or through direct extension from an infected area, such as the middle ear or paranasal sinuses. Common microorganisms include meningococcus, streptococcus, staphylococcus, and pneumococcus. Meningitis could also be caused by a contaminated head injury, an infected shunt, or contaminated lumbar puncture. The signs and symptoms of meningitis include elevated temperature, chills, disorientation and a headache, often severe, nausea and vomiting, nuchal rigidity, stiffness of the neck, photophobia, altered level of consciousness, and multiple petechiae on the body. The common signs of nuchal rigidity, positive Kernig's and Bruditsky's sign. These tests are usually performed by the healthcare provider. What happens with the Bruditsky's is the physician will have the patient lie flat on his or her back, supine. Then the physician will lift the patient's head off the examining couch. If the patient has meningitis, his or her legs will involuntarily lift. This is a positive Bruditsky sign. With Kernig's sign, the physician will have the patient lie flat on his or her back, supine. The physician will flex the thigh and put the knee at a 90-degree angle. When an attempt to extend the knee, the patient feels a lot of pain, leading to resistance. This is a positive Kernig's sign. Your teacher told you with meningitis, the patient may display signs and symptoms of increased cranial pressure. So what are your worries about meningitis and increased intracranial pressure if left untreated? If left untreated, it can result in brain herniation and damage. That's not good. All right. Let's discuss another type of posturing that could be seen with meningitis. A patient with meningitis or even tetanus may present with opisthotonos. I know many of you have not heard that term before, so I will spell it. O-P-I-S-T-H-O-T-O-N-O-S. Look at the picture on the screen. Opisthotonos is extreme hyperextension of the head and arching of the back due to irritation of the meninges. The person is usually rigid and arches their back with their head thrown backward. If a person with opisthotonos lies on their back, only the back of their head and heels touch the surface they are on. Let's talk about treatment for meningitis. Treatment according to causative pathogen as found by a lumbar puncture. Lumbar puncture is usually done by inserting a needle between L3 and L4 or L4 to L5. There will be bed rest, IV fluids, analgesics for pain and fever, anticonvulsants, and corticosteroids will be given. Pathogen-specific antibiotics include for meningococcus, penicillin, or cephalosporins. Contacts rifampin or Cipro, pneumococcal, PCN, cephalosporins, and also vancomycin. Let's talk about Parkinson's disease. Can you name two famous people who had or have Parkinson's? Muhammad Ali and Michael J. Fox. Parkinson's is a neurodegenerative disease. Normally, the neurons found in the substantia nigra produce dopamine. Dopamine is a chemical that controls movements of the human body by relaying messages between the substantia nigra and other parts of the brain. Dopamine helps us have smooth, coordinated muscle movements. But this doesn't happen here. The brain slowly stops producing dopamine, and with less and less dopamine, there is less and less ability to regulate movement, body, and emotions. The signs and symptoms include stooped posture, slow and shuffling gait, pill rolling, mask-like faces, uncontrolled drooling, a rare arm swinging with walking, labile and depressed sleep disturbances, oily skin, excessive perspiration, orthostatic hypotension, a change in voice, dysarthria, and echolalia. What is echolalia? Well, echolalia is a repetition of words. It kind of sounds like this. Hey, are you in pain? And Mr. Smith responds, hey, are you in pain? And then he will probably answer, yes, I am in pain. Parkinson's has several stages, stages 1 to 5. Stage 1 is the initial phase. We see hand and arm trembling, weakness, and unilateral involvement. Stage 2 is the mild phase. We see mask-like faces, shuffling, bilateral involvement. Stage 3 is the moderate phase. We see increased gait disturbances. Stage 4 is the severe phase. This is akinesia and rigidity. In stage 5, we see complete dependence. Levodopa is the most important first-line drug for the management of Parkinson's. In the brain, it changes into dopamine. And we know Parkinson's is a disease of low dopamine. Remember, levodopa causes nausea, and the patient should avoid foods high in vitamin B6 like egg yolks, peanuts, meats, and high-protein foods. Why? Because foods high in vitamin B6 reduce the effects of levodopa. Levodopa is almost always given in combination with carbidopa. Why? Because 1, it prevents the nausea and vomiting that can be caused by levodopa alone. 2, carbidopa is a levodopa enhancer. This means only a lower dose of levodopa is needed, and the combination of levodopa-carbidopa is not affected by high-protein foods or foods high in vitamin B6, so the patient has fewer restrictions. Other treatments include eldepril, a MAO inhibitor which decreases the breakdown of dopamine, dopamine agonists which stimulate dopamine receptors but have side effects such as nausea, drowsiness, postural hypotension, and hallucinations. Mirapex and Requip mimic the actions of dopamine. Levodopa-carbidopa, used as disease progresses and is associated with the wearing off phenomenon. What is the wearing off phenomenon? It is the reemergence of Parkinsonian symptoms, either motor or non-motor, before the following scheduled treatment dose. Amantadine, used to treat the wearing off signs and symptoms. Anticholinergics are also used. And your teacher told you anticholinergics dry up secretions. Yes, they dry up slud, salivation, lacrimation, urination, and defecation. I will say it again. Anticholinergics dry up salivation, lacrimation, urination, and defecation. Surgical management may be needed when medication therapy is not effective Deep brain stimulation, when meds no longer work and the patient has had Parkinson's disease for longer than 5 years. The DBS system involves an electrode inserted into a small opening in the skull, which is connected to a neurostimulator, or a battery pack, which is implanted under the skin near the collarbone. It blocks electrical signals from targeted areas in the brain. It helps treat tremor, rigidity, stiffness, slowed movements, and walking problems. What are your nursing considerations and interventions? Maintain mobility and flexibility by range of motions. Encourage self-care as much as possible. Remember, what they don't use, they will lose. Monitor sleep patterns to avoid injury. We do not want our patient falling down. They may need soft or thickened foods. Stool softeners may be needed if the patient becomes constipated. Speech therapy may also be needed. And remember, one of the most important jobs we do as nurses, provide psychosocial support to the patient and their family. Let's discuss spinal cord injury. I know your teachers taught you about cervical, thoracic, and lumbar vertebrae. How many do we have? Are you ready to learn an easy way to remember your vertebrae? Okay, so what time do people going to work have breakfast? 7 a.m. How about lunch? 12 noon. How about dinner? 5 p.m. 7, 12, 5. So here we go. Cervical, 7 vertebrae. Thoracic, 12 vertebrae. Lumbar, 5 vertebrae. I'll say it again. Cervical, 7 vertebrae. Thoracic, 12 vertebrae. Lumbar, 5 vertebrae. Now, the common causes of spinal cord injuries include automobile accidents, athletic injuries, diving, hard contact sports, falls, gunshot wounds, stab wounds, and industrial accidents. Common locations for spinal cord injuries include the flexion extension injuries like whiplash, commonly between C4 and C7. T11, 12, and L1 are frequent sites of spinal cord injuries resulting from falls. Injuries above C8, quadriplegic. Injuries below C8 could be paraplegic. The mechanisms of spinal cord injury: for flexion extension, whiplash seen with rapid deceleration injuries. Subluxation, incomplete or partial dislocation. Torsion, a twisting of the spinal cord, and there's compression. Pathophysiological changes associated with spinal cord injuries include a damage to the cord, which may be a concussion, a contusion, laceration, compression, or complete transection of the cord, or the cord's response to injury, which could include a hemorrhage, ischemia, and edema. C3, 4, and 5 keeps the diaphragm alive. Injuries are classified as complete or incomplete, and by the extent, the level, and mechanism of injury. High-dose corticosteroids are used to control edema during the first 3 hours. Spinal cord injuries are usually treated with high-dose steroids. Did you know long-term steroid use can cause drug-induced Cushing's syndrome? Side effects include hypertension, hypokalemia, hypernatremia without causing peripheral edema, metabolic alkalosis, and connective tissue weakness and immunocompromised. Let's talk about spinal shock. This may last from days to weeks, reversal indicated by the return of reflex activity. Spinal shock is shock of the spine. When injury occurs and for a period of time thereafter, the spinal cord responds by swelling. When a spinal cord injury is caused due to trauma, the body goes into a state known as spinal shock. While spinal shock begins within a few minutes of the injury, it may take several hours before the full effects occur. During spinal shock, the nervous system is unable to transmit signals. Most times, spinal shock lasts for about 4 to 6 weeks following the injury, but it can last longer. Spinal shock is characterized by flaccid paralysis, loss of reflex activity below the level of lesion, bradycardia, possible paralytic ileus, and hypotension. In some rare cases, spinal cord shock can last for several months. The loss of these signals will affect the person's movement, sensation, and how well the body's system functions. Treatment begins with the emergency medical personnel who make an initial evaluation and immobilize the patient for transport. Immediate medical care within the first 8 hours following the injury is critical to the patient's recovery. Treatment starts with steroid drugs. These can be administered at the scene by an air ambulance doctor or trained paramedic. These drugs reduce inflammation in the injured area and help to prevent further damage to cellular membranes that can cause nerve death. Autonomic dysreflexia is a condition that can occur in anyone who has had a spinal cord injury at or above the T6 level. Autonomic dysreflexia can be caused by a number of things. The most common causes are a full bladder, bladder infection, severe constipation, or pressure sores. Anything that would normally cause pain or discomfort below the level of the spinal cord injury can trigger dysreflexia. Autonomic dysreflexia can occur during medical tests or procedures and need to be watched for. Can you point to T6 on your body? Are you pointing to your nipple line? Your T6 is at the xiphosternum. Let me spell that for you. XIPHISTERNUM. That's also known as the xiphoid process. That's where the T6 is. It is related to disconnections between the body below the injury and the control mechanisms for blood pressure and heart function. It causes the blood pressure to rise to potentially dangerous levels. The symptoms that occur with autonomic dysreflexia are directly related to the types of responses that happen in the sympathetic and parasympathetic nervous systems. Symptoms include high blood pressure with systolic greater than 200, pounding headaches, spots before the eyes or vision are the direct results of the high blood pressure that occurs when blood vessels below the injury constrict. The body responds by dilating blood vessels above the injury, causing flushing of the skin, sweating, and occasionally goosebumps. Some patients describe nasal stuffiness and will feel very anxious. Did you know that uncontrolled autonomic dysreflexia can cause a stroke if not treated? Class, this is a serious medical emergency. You need to act quickly. Don't wait. Elevate the head of the bed. This causes orthostatic hypotension. Place them in the high Fowler position. Notify the physician. Identify cause and alleviate. If the bladder is full, check the catheter. If it's skin, remove pressure. If it's a full bowel, empty it. Remove support hose and abdominal binder. Monitor blood pressure. Remember, with autonomic dysreflexia, blood pressure is greater than 200/100, and give PRN medication to lower blood pressure. Treatment for autonomic dysreflexia is essential. Request help because this is a medical emergency. Head of the bed needs to be up. Check blood pressure every 5 minutes. Do a straight catheter of the bladder. Evaluate the bowels. Remove tight clothing. Check orthotics. Check the skin, toenails. Report to the doctor if the blood pressure still won't decrease. Place anesthetic ointment on the tip of the catheter before insertion. Check room to ensure it's not too cool. This could lead to fecal impaction. Medications are generally used only if the offending trigger or stimulus cannot be identified and removed, or when an episode persists even after removal of the suspected cause. During the emergent phase, the following medications may be given: Procardia sublingual, nitroglycerin, clonidine, or hydralazine. For chronic recurrent episode prevention, Prazosin, Minipress, and clonidine, Catrapress are the medications of choice. Autonomic dysreflexia can be prevented by using frequent pressure relief in the bed or chair, a kinetic bed to promote blood flow, protect the skin from breakdown, avoid sunburns and scalds, avoid overexposure, use a number 15 or greater sunscreen, watch that water temperature, maintain a regular bowel program, a well-balanced diet and adequate fluid intake, keep urine dilute and acidic to help prevent urinary tract infections, compliance with medications, keeping catheter tubing free of kinks, and keep the drainage bags empty. Remember, you are more than a conqueror and you will be successful. Join me as we review core content in the next unit.